All right, so we're gonna start. So the objectives really, we're gonna identify some of the instruments used in anesthesia, appropriate application, what other devices can be used, and again, as in my overview, you're gonna be again introduced to the principle of say basic monitors. That, and you have to tell me when I get there what is the most basic of all the monitors that need to be present. All right. Expect full participation. You can ask questions in the chat. I will answer you. I'm ahead of your chat. Thank you. And we can go. Some things are not going to make quite as much sense as they normally would, because you just are not in the clinical space just yet. But as I say, you of all the groups have the greatest advantage because you're doing a lot of your lectures and stuff, not just in anesthesia, but in the other clinical specialties, quite close to when you're coming to turn in person. All right, so we're gonna go through, let's start off with endotracheal tubes. Endotracheal tubes are tubes that so this lecture is, the PowerPoint is done by Dr. Minot, and I'm just using it, but I do it a little differently, but we're gonna do it as she has it down here. So endotracheal tubes, what are the indications for it? It means that we're gonna secure the airway, but what does that phrase mean? What does that phrase mean? That phrase means a cuffed tube placed below the vocal cords. That's really what that means when you say you want to secure an airway. And that cuffed tube may be an endotracheal tube. That's what it's commonly used. But it could be a tracheostomy tube, for example, if there's an indication for a tracheostomy, right? It's composed of plastic or rubber. These days, a lot of plastic. And there are some features on it that you will note. There is a connector here. There is a radial opaque line that only becomes visible on the outside of it right here, at this side. If you know, you can't see it on the upper part of the tube. Sorry.
No.
Yeah.
Not in your point.
Upper. Yeah.
Oh, there it is now.
I caught myself. You're seeing it on the lower part of the tube right there. All right. There are different sizes, and ID says the internal diameter, and OD or written on it will tell you that's the external diameter. All right. So there's a connector. There's the tube. There are markings on that tube. There's a radial opaque line. There is a bulb. There's one outside that's called a pilot balloon. And then there's the bulb. And then there are holes at the end of the tube. And note the sizes. They're a bit smaller for women. 7 to 7.5 is what we tend to use. 8 to 9 is what we use for men, because their larynx are naturally larger than women. You can have pediatric sized tubes naturally, of course, and that's based on age and weight. And the markings on the tube are usually, and we'll get back to the tube, 18 to 20 centimeters for women. I would say 20 to maybe about 25, 26 on very tall men. They would go up to that if they have long necks. And then there is sometimes a depth marker that is on the tip of the tube, which I'm hoping to show you. There's a bevel, which is the slanting. See that tube? The end of it is slanted. It's not flat on. All right, it tends to be left facing. And then the Murphy's eye, which is the additional opening. It's on the side of the tube, at the tip of the tube. It's called a Murphy's eye, and it's an additional aperture just in case this one gets blocked. So the pediatric endotracheal tube sizes for uncuffed, and we can use uncuffed tubes up to about age 10 sometimes. Age of the patient upon 4 plus 4. For newborns, it's a 3 or 3.5. If that newborn is a premature newborn, that size goes down to 2.5. And then a cuffed endotracheal tube, right? Because it has to accommodate the cuff, put some air in the cuff. It's age upon 4 with a smaller number added. All right. Classically, the child needs to be at least 1 year and less than 8. All right. So these are the endotracheal tubes. These are the pediatric ones. Notice they're small. Yeah, this is a slightly bigger tube. These are uncuffed, they have no cuff. And then there's are for an older child, say 10, or a small adult, maybe, and they have cuffs on them. So what's the purpose of the cuff? The purpose of the cuff is to allow us to put air through this. This is a tubing, and this is what we call a pilot balloon. A pilot balloon essentially is a balloon that simulates what state the cuff is in. If is the cuff down, the pilot balloon is flat. If the cuff is up, then it's also distended. What it does is that it allows a proper seal in the trachea, just below the larynx, and therefore allows us to be able to ventilate. So when we attach to hair an ambu bag, for example, a self-inflating bag or an anesthetic circuit, and we squeeze that bag to squeeze air or gas in the patient, then there is no leak around the tube in the trachea. It goes into the lungs and then back through the system. All right? When we spoke about on the previous slide about the depth marker here, 3 centimeters proximal to the tube, let me just show you in this slide. So in the pediatric one, if you are to look carefully, there is a line from the tip of the tube to about there. It means that acts as a guide, and therefore the vocal cords should not be higher than that, or else too much of the tube will be in, and it's likely to go either down to the carina or worse yet into the right or the left bronchus. So first question, in an adult, if I were to inadvertently put an endotracheal tube down one of the bronchi, the main bronchi, which one is it likely to go down? Let's start at the top. Aki, at the top.
And that would be the right.
And why would that be so, Aki?
It's more vertical, so it's more in line with the trachea, and it's wider.
And it's a little wider, yes. Correct. Can you hazard a guess what would happen if we were to inadvertently put a tube down that side?
You could overinflate that lung and damage it.
All right, well, that's a possibility. What else? So what would you see clinically?
Would only getting air on one side. So
Well, even if you're getting on both, it would be more on that side. Good job. Good job. All right, so it's more likely in the adult. You will learn that in children, especially young children, because the way when they're born, the differential pressures in the heart has not yet led to the heart being the way it is in an adult, and therefore the difference in the anatomy quite so much. The bronchi in a child, the tube can go down either the right or the left. So if you think that tube is down too far, you have to check which side it is on in a child, especially in a younger child. All right, in the adult, so just pointing out again, the guide to help you with intubation. In the adult, notice that there's a tip, then there's a cuff, and you see these two lines? It's on both these tubes actually. That is the guide in the adult to say that the cords should be at least at that one and definitely not above the upper one. Ideally, it should lie between the two so that we can be certain that it is not down too far. So how would we know it's down too far? From the time of intubation, because we're doing it under direct vision, even if we're using a video laryngoscope, you can see where the tube goes and how far it's in. But also along here, you see, remember we told you, in a woman it's 20 to 22 centimeters. It should be in a man no more than about 25, 26. It's actually along the tube. So if I intubate a female patient and that tube is down at 24 centimeters, then maybe I'm down to, maybe I'm in the right, right? So you have to remember that. Right, so the cuffs, they provide air seal to prevent aspiration, efficient ventilation, there's no leak. You can attach it to a self-sealing bag or an anesthetic circuit. The glottis is the narrowest point in an adult. Everybody knows what the glottis is. The glottis is the larynx, right? And the rhemoglottis is that space between the vocal cords, right? In a child, the cricoid is the narrowest point in the airway, and which is why you can use an uncuffed tube because it is circular. Questions so far? None yet. Cuffs, we really want them to be low volume. Low pressure, high volume, because that makes it not put so much pressure on the tracheal mucosa, which can both, once you put it in the tracheal mucosa, you can occlude the lymphatics and lead to swelling of the mucosa, and that leads to stridor at extubation, or you can lead to pressure necrosis and lead to stenosis and lung problem. However, it does not, the lower pressure, high volume doesn't give quite as good a prevention against aspiration. So you have to be aware of that. Does, but not to the same extent. All right, mostly oral. That's the standard way that we insert the endotracheal tube. With children, you have to be careful with the tonsils. We use nasal intubation, meaning we go through the nose for ENT and dental surgery. And if we have long-term ventilation, we may want to put it there. All right. So this is just showing where, so through the nose, tube comes through the nasal passage into the nasopharynx, down into the hypopharynx, and into the trachea, larynx and trachea. Yeah? Epiglottis is anterior, and we're putting the tube just below it. Right? This is what the glottis looks like. When you look at through a laryngoscope, this is the epiglottis here. These are the cartilages of the larynx, the arytenoids, and those are the true vocal cords. And the space is the rima glottises. All right? Everybody sees that? Everybody's happy? Let's see. I'm not sure if this will work. Okay. I'm coming, guys. I'm just seeing if I can.
Endotracheal intubation is an important part of airway management. Pre-oxygenate for a minimum of reflexes. Lift may be all it takes. Full onset of the drugs, take a moment, not too tight with 3 or 4 fingers. Open the patient's mouth with the blade. This is very much a team effort. Open the patient's mouth with your right hand and hold the laryngoscope in your left. Not too tight.
Look, we're not seeing your screen. Remember, you're sharing through Blackboard.
I'm not. Yeah, I know that. I know that you are not seeing it just yet. I was trying to find the exact position on the video. This is a video that is on the on OUR VLE. All right. Share application, Chrome tab. Here we go. All right, you all are seeing me now, yes?
Blade as possible for precision and control.
Yes, Doc, we're seeing.
Insert the blade in the right side of the mouth,
We look at
carefully pushing the tongue aside.
Right.
The aim is to create an unobstructed line of sight to the larynx by pushing the tongue to the left and lifting
And
the
no,
epiglottis,
that's a
exposing
real.
the vocal cords.
Let's stop that. So that's actually a recording of what it looks like in a real live person, not just a simulation, right? Everybody's seeing me, yes? My screen is being shared, yes?
Yes, sir.
All right, so this is the epiglottis. All right? These are the arytenoids. And down there is the cords, right? In the distance, so you can see the airway, but that's really tracheal. And this is just below the cord. So let me go back at oops. All right, he switches immediately from here. So keep your eyes on it, guys.
To the larynx by pushing the tongue to the left and lifting.
You see? So as soon as that's the vision you want to see, right? Epiglottis, yes? Arytenoids, the cords on either side, and that's the trachea down there. Okay.
The epiglottis, exposing the vocal cords. This requires precision, not brute force. A common mistake at this point is leaning forward, as it feels this will give a better. It doesn't. Stand upright with the left arm at a 90-degree angle tucked in towards your body. This allows for better ergonomics, better communication with the team, and a better overview of the ventilator, the timer, and the patient. Let's see the laryngoscopy once again. Advance the blade until you see the epiglottis and place the tip in the vallecula, the recess at the base of the tongue.
So you heard, where is the vallecula? You can see it now here. So somebody tell me, where would tongue be on this, on the inset? Where would tongue be on the anatomy? Firstly, where is anterior?
Top, the top.
Top is anterior, all right? So the blade, you can just see the blade, that's the vallecula. The vallecula is between tongue and the epiglottis, right? So therefore, if I ask you in your MCQ, right, tongue, so how do you encounter it? Tongue, vallecula, epiglottis. Agreed? Right? This is the epiglottis here. You're not quite seeing the arytenoids, they're just coming into view. So when I go in as an anesthetist, if I have a difficult airway, if I can glimpse that epiglottis and I know where the arytenoids are,
At this point, you can start to apply some force in the
I know
direction of the
where the
laryngoscope shaft.
trachea is. See?
Sometimes a light external force on the larynx can make the vocal cords spring to view. Ask for your assistant's
See?
hand
Vocal
and move it to
cords,
apply
there.
backwards, upwards, rightward pressure, or burp for short. Make
See?
sure you don't pinch the lips and do not exert any pressure
So she has
on
the
blunt
endotracheal tube.
incisors.
Notice it has
By
the
now,
guide.
you hopefully have a clear view
With
of
the
the
two
opening of the
rings on it.
trachea, a dark slit between the pale vocal cords. Insert the tube carefully. Sometimes a gentle rotation is required to pass
Right.
the vocal cords.
Cuff
Advance the tip
in,
until the cuff has
first
disappeared
black.
and the vocal cords
Okay.
are between the two black
Now
lines.
she's put it, has
Ask
she
for
put it
inflation
in
of the
too
cuff
far or
and
too? Is it too far in or not? Too far, correct. She did not need, and you see, the thing about this is when you're using, especially when you're using a laryngoscope like that, where the screen is up and everybody can see, I immediately know, I'm sitting, I don't know how long this video is done, and oh, she's in too far, right? She doesn't need, once that first line disappears, cord just needs to rest between the two. Definitely, you should be seen or stop at the top, the top one. Right, let's go back to our presentation. Yeah. Why are you? So that was oral oral insertion. All right. There's a few things. The connector that is on the tube, you'll see it on the laryngeal mask. It's a little different on the mask, but it's the outer version. It's a standard 15 millimeters. That's why things can connect. In an anesthetic, I don't have to think, oh, is this going to fit? All right? There's a standard to which the equipment is made so that you can be sure that even if you have to interchange equipment, they should connect. All right? 15 millimeters, the connection is. And it attaches to all airways. All right, you have some special endotracheal tube. You don't need to know a lot about them, except you just need to know there are special ones. A few you should know about are the ones that are what we call a ray tube sometimes, but they're preformed, they're north or south facing. And for those, what it is that they are done for specific surgery. So let's think about it for a minute. All right, this is a south facing tube and this is a north facing tube. All right, Aliano?
No pointer there. Not seeing your pointer.
Sorry, thank you. This is a south facing tube and that is a north facing tube. All right, so if you just think for a moment how you would put that tube in, right? Laryngoscope is this way, I'm putting in the tube that way. Where would this tube, the south tube, where would Alana?
I'm thinking about it, but I'm not quite sure, Doc.
Yeah, but since you thought about it, give me an answer. You're not quite sure is not an answer, Aliano. I'm quite aware you're not in the area. I'm quite aware you may not have seen it, right? It's south facing. You think that would give you any clue?
So you're
Alison?
asking if you put in the laryngoscope, where would you place this tube?
No, we would always place the tube in the larynx. That doesn't change. It's going to go in the larynx. But I want to know, these tubes are preformed. I can't take that bend out of them. That's how they are made. So I'm asking you, if I were to put one of those the tube in, what direction would it point? How would it be in the body?
So I guess it would face downwards, towards the patient's lower limbs.
Yes, that would be the south facing. So it's in the mouth and it's facing towards the lower limb or the feet. Okay, fine. Where would the north one face?
So that would be the opposite.
And where is the opposite? Because opposite don't help me. No, I'm a little ignorant, so you have to help me.
So
It
it
would
would then
face.
come to face back towards the patient's, towards the upper, what would you call it, cephalad direction.
Like where your head, Aliana, we can use normal terms like that in
Oh,
medicine
but I
here.
figured that, it was in the head, so I didn't really know how to explain it.
Oh, I see. All right. I take the point. So, Alison, you now have the difficult question. Did you hear me already tell you it's difficult? It's not really. So we have put these tubes in the mouth. Let's start off with that. The truth is we tend to use the north facing in the nose, through the nose into the larynx. So we've put it in the mouth, Alison, a south facing. So we've put it in the mouth and it's facing down like that. Why would I want to do that? Can you guess?
You're saying why?
Alison,
Yes, I'm hearing you, Dr. Chris.
why would I want to use a south facing tube? Let's think about it. Why would I want to do that? Antoine, can you help her out? It's okay, Alison.
Not really, Doc.
What? You're not even gonna guess, Antoine?
No, Doc, I got logged out and I missed like 5 minutes or so, so I'm not really
I'm,
up to
I'm so sorry. Okay.
date. Yeah.
Eileen, help out Alison.
You said why would you want to place it down?
Yes. Why would I want to put in a tube that is purposely bent down?
For to prevent choking or for easy removal?
No, we could put in a normal, not preformed tube. In other words, why would I choose this type of tube over just a normal one? Any takers? Hands up. Don't all speak. Hands up. Any takers? Christina. Yes, Christina.
Well, Doc, I would think that each of those different facing tubes gives better surgical access, like creates a more accessible surgical field for nasal or oral cavity surgery, for example.
Okay, so which one would I use? Which of those two would I use for nasal surgery, for example?
The south facing, because you're completely avoiding upper.
So the connection of the anesthetic system to the tube would be completely out of the way. Yeah? And like what would we need? We would use a north facing for?
If you wanted to do anything below the level of the nose, you said you can put the north facing in the nose. So if you have a oral or dental surgery,
right. What else?
If you're going towards the neck as well, I guess it would give you more room for
good job,
moving
Christina,
around.
right? Yeah, good job. Thank you. So we use special tubes when we need special situations. The most common special tubes that you'll come across when you come to clinics are south facing or north facing tube. There are others. So if we're doing laser surgery, like they're cauterizing using laser on the larynx, you need a special tube so the tube doesn't catch fire or melt and you lose the airway. Yes, that can happen. Actually, you can have an airway fire. And then this tube that you see not tied into a knot, if you notice, the lumen is actually well preserved. That's because, and it's not very clear on this one. Oh, sorry, you can't see my pointer now. It's not very obvious on this one, but on this one, there is a metal coil inside the actual plastic of the tube. And what that does, it allows the tube to kind of bend, go in any direction, but it preserves the aperture. I don't know if it preserves the opening of the tube. It does not kink. So when would we need a tube like that? When would we need to ascertain, to ensure that the airway is good and we're not going to get a kink? Really, any surgery that is being done in odd positions. So when we put the patient prone, right, face down, they're operating on the back or the neck or something. If we're going to put the patient in a sitting position, as they do for some neurosurgery in some centers, right? Those are times when we need a tube. If we have a tumor that's pushing the airway, we want to put a tube in the largest tube we can get in, but that we know won't kink. All right, so that's when we need. So the principle you need to know south and north facing tubes. Those are the ones you're gonna commonly come across. And you need to know there are special tubes used for special occasions. All right? But that's a standard ET tube. You've seen that before. This is an uncuffed one, and it's a little clearer now that you can see the measurements. It has 22 centimeters, 24 centimeters on it. The connector is standard. All right? This is a quick, fast. Everybody, this is what kind of tube? Hello, hello.
North facing.
North facing. Good job. And the other two are? South facing. Good job. But if you notice, one is cuffed and one is uncuffed. So even in these special tubes, you can have cuffed or uncuffed tubes. All right? Okay, you have a time if we want to do operation on the actual larynx, on the vocal cords. We use a smaller tube, but a longer one, so that because it's for an adult, so it's the size of a pediatric tube, but it is longer to accommodate the longer neck of the adult, and it's smaller so that it doesn't take up so much space, and the surgeons can work around the tube. That's what a microlaryngeal tube is, right? And this slide I like because this is the pediatric 5.0. This is a microlaryngeal tube. So it's same thing, internal diameter of 5.2 millimeter, but it's a way longer one. Can you see that? Yeah, and it's always cuffed because, the cuff is usually quite large because you have to put enough in it so that it protects the trachea. Because of course, if you're operating on the vocal cords, where would blood go? Would it come up into the oropharynx? It may, but it's likely to go down into the lungs as well, yes? And if you're removing polyps, which are little pieces of tissue, those little pieces of tissues can also go down the lungs, and that we don't want. All right? A double lumen tube is another special tube, and you simply need to know about it because when we need to isolate a lung, something is wrong with one of the lungs and we need to operate, so the other lung needs to be deflated or removed or something, then we need a special arrangement. For it's called a double lumen tube. All right? Very complicated, and you get big numbers like 39 because they're French numbers. All right? One is usually blue and the other is usually white, clear, transparent, because one is for bronchus and the other is for trachea. All right? So another special tube that you need to know. Right? And there are right-sided tubes and left-sided, tube. All right, so we'll go on to the laryngeal mask airway. Right? The laryngeal mask airway comes from a group of airways that's called supraglottic airway. Sometimes you'll see them written as SGA. Supraglottic airways. If you see from the picture, inserted orally, sits over the introitus of the larynx with the epiglottis upright and pressed against the base of the tongue, and the tip of the laryngeal mask sits in the esophagus. This is when it is ideally placed. Ideally, we use it in a patient who is not at risk for aspiration because, as you see, this is not a secure airway. Remember what I said the definition of a secure airway was? Let's go. Secure airway was a somebody talking to me. Cuffed tube placed below the vocal cords. Kafan, you have to say the whole thing, not just cuffed. Right? It has to be placed below the cords. And therefore a secure airway could be an endotracheal tube or a tracheostomy tube. Don't forget the tracheostomy tube. Sometimes we think only of the endotracheal tube. Right? So this does not afford a secure airway. When saying that, however, the marked increase in aspiration that they expected when the laryngeal mask came onto the anesthetic scene has not materialized. So it's actually a lot safer than they first thought. However, there is an aspiration risk, right? Wherever there's full stomach, there's risk of aspiration. Wherever there's no secure airway, there's risk of aspiration. Where there is the risk of aspiration, there's an increased chance of aspiration pneumonitis or pneumonia or infection, etc. Those are things those are threads you have to put in your head. All right, that's how you learn in a generic manner. He said, this increases the risk of aspiration. Okay, what else? All right. So it has an elliptical cuff at the distal end. It does have a pilot balloon with a self-sealing valve to indicate the cuff. And there are fenestrations at the junction of the tube and the cuff. There are different types of LMAs as well. All right. Excuse me. This one is the same as the reinforced endotracheal tube, meaning there is a spiral. That's why you get that impression. There's a spiral, a metal spiral within the tube, and makes it not able to keep like that. Even if you turn it into almost in a U, it will still preserve the lumen. All right. The ProSeal, it has the laryngeal mask, but additionally there's a hole right at the tip that is connected to another tube through which you can aspirate esophageal gastric secretions. Remember, when the laryngeal mask sits properly, the tip rests right in the upper esophagus. So therefore, the procele, that would be resting in the esophagus, and you can actually suction through it. And then you have laryngeal mask airway. Sometimes it's impossible to intubate a patient, and you will deal with the difficulty when you come. When you do pre-op assessments and assessing the airway, it can be a difficult airway. But sometimes the rescue method is to insert an LMA, and if that is so, we try to use an intubating LMA so that we can then put a specially sized endotracheal tube through that LMA, past the cords. Usually we can see. All right. What is the biggest, most problematic issue with LMAs? Let's go. It is not a secure airway. That's one way of saying it. It is a supraglottic airway. That's another way of saying it. It does not protect completely against aspiration. That's another way of saying it. I just said three different ways, the same thing. All right? That's the greatest limitation for it. I reiterate that it has turned out not to be as bad as was expected when it was first brought into clinical practice, and has actually been a great savior, especially in the unexpected difficult airway or in the can't ventilate, can't oxygenate group of patients while we get to a cricothyroidotomy. Okay. In some patients, about 10%, again, you'll get obstruction, and the tube just won't sit sometimes. So no matter what, maybe it's a patient's anatomy, maybe it just does not sit, and therefore you cannot use it all the time. Right? So we go again. The anatomy connector, the airway tube, it opens into the sort of mask itself. This is the cuff that can be inflated, and that's the pilot balloon. Got it? This is the procele, as I said. This is a better view of it. So it sits like a normal laryngeal mask, but there's this tube that you can aspirate through, aspirate the esophagus and the stomach, right? And the intubating one. All right. There has been a new generation of supraglottic airways or supraglottic devices. And iGel is one such. These are anesthetic, these are anatomically shaped. So they have worked out the anatomy of the larynx and the supraglottis area, and it fits. So therefore it does not need a cuff. Right? It has a cuff, but it's not inflatable, rather. That's what I should say. It's not. So it has a lip like a mask and sits, but it doesn't have a cuff. And the tube is kind of wide because they have a built-in bite block. Let me see if she has another one. Yes, Jessica. Talk up, please.
Hi, Doc. I was wondering which one of the two is easier to place, the normal tracheal tube or the laryngeal mask airway?
Okay. Question on the floor, guys. Everybody heard a question on the floor by Miss Gay? So I want to hear what you think. What you think. I should have polled you with that, you know. I should do a poll.
Oh, okay. So don't answer you. Or?
No, don't answer me. Don't answer me yet. Hold on, hold on. Don't answer me. Just hold it. You can close your mic, but we'll come back to you. Bijan, your turn. Shallow. Mr. Shallow. Yes, go. Which do you think is the easier to place?
I would say the laryngeal mask.
Okay, Bernardo, your vote. Spencer.
Endotracheal tube.
The endotracheal tube. That's 1-1. Gay, you're counting? That's 1-1, okay?
Yeah, okay, yeah.
You keep.
Yeah, I'm keeping. I'll
Keep that.
Okay.
Bilal, which do you think? Bilal. Anybody call him for me? Call him for me. Somebody call me. Help him call for me. Bilal. Gone to sleep. Okay, Brittany.
I think the endotracheal tube would be easier to place.
Endotracheal tube. Camille.
I think endotracheal tube.
Okay. Natu? Woo. Harvey. Colin Harvey. Come on in.
Doc, I'm here.
Yeah. Yeah.
The the eye gel one.
The IG, right. The laryngeal mask airway. Okay. You have Gay, you are the counter, you know.
I'm marking 3-2.
Okay, all right. Cool. Carly's, Miss Forrester, let's go.
Laryngeal mask.
Laryngeal mask. Chad.
I also say the laryngeal mask airway.
All right. Chevon, let's go.
I think the endotracheal tube.
Okay. Christian.
Laryngeal mask.
Okay. Cheyenne. Is Cheyenne? Is Cheyenne still there?
Yes, it's Cheyenne. I'm thinking the laryngeal mask as well.
Laryngeal mask. Gay, you're on top of the counting?
Yeah.
All right. Sierra.
Laryngeal mask as well.
Danielle. Drake's this one. Drake's I'm talking to now.
Laryngeal mask airway.
Robert. Laryngeal mask, Robert said. Did you see that? I'm gay.
Yeah.
Dominic.
Laryngeal mask.
Gabrielle.
Laryngeal mask airway.
Hanley.
The laryngeal mask airway.
Okay. Harshil, are you with me? Laryngeal mask. Imani. ET tube, Imani says. Jabari. No, this is Abel now.
Laryngeal mask.
Laryngeal mask. You don't sound confident, Abel. We want no fence sitters, you know, sir.
No. I said it, but what happened? I had my headphones plugged in. Laryngeal mask.
Okay, sir. Right. It have to be definitive. Morgan. Jabari.
Yeah, laryngeal mask.
Okay. Jamak.
Laryngeal mask.
All right. Jehan. Miss Guppy. Guppy, where are you? Okay, ET Tube. Thank you. Jessica, you can't vote yet. You're the last one to vote.
Okay.
I'll go.
Yeah.
Sorry. I'll go with the laryngeal mask. Well, I'm going with.
You're going with
Yeah.
Joseph. Zeddy, laryngeal mask. Okay, Janelle, you just come. You know what going? LMA. All right, Kavito.
Laryngeal mask.
All right, Karen.
Yeah, I'd go with the laryngeal mask.
Kimberly. Kimberly Harvey. What a guan. Christina.
I'm gonna say the LMA, Doc.
Okay. Leo?
It's the laryngeal mass, Doc.
Okay. Levine?
Mask airway.
So just tell us the writing, Kimberly, since it's giving you. I'm sorry, Levine, go ahead. I was just responding to Kimberly, who's having a little trouble.
Okay, Doc. The laryngeal mask airway.
Okay, Mikhail? Robert? Patel? Miss Patel? Is everyone hearing me or no? Is everyone hearing me?
I'm hearing you, yeah.
Okay. All right. I just wonder for a moment. Matthew, Roden?
The laryngeal mass, Doc.
Okay. Mayo?
The laryngeal mass, Doc.
Okay. Morgan? Morgan the girl? Laryngeal mask. Raquel? Raquel. Laryngeal mask. Mr. Kane? LMA. Rochelle? Bryson, talk no man. I see a mic and it gone. Oh, cha. Rodion?
Rodine, LMA.
Rodine. Sorry, miss. Thank you very much. Rodine, LMA. Ryan Pedro says LMA as well. Sabrina?
LMA as well, Doc.
Sion?
LMA, Doc.
Shanique? Shanique, where are you? Okay, Bilal says LMA. You just wake up, Bilal. Morning. Shanique, sorry.
The LMA.
LMA, okay. Tonya?
Laryngeal mask.
Laryngeal mask. Veronique? Laryngeal mask. Okay, Gay, you can now vote.
I was gonna vote ET2, honestly.
ET2. That's right. Good. I'm glad you're honest. Okay,
Yeah.
tell me the number.
Okay,
Everybody, pull time.
so I got 37 for laryngeal mask and 7 for ET tube.
Only 7.
Yeah,
All
only
right.
7.
So who wants to make the case for the LMA? To tell me why they said an LMA. What did Chad say? Chad said LMA? Chad, no, hold on. Shallow. Bernardo. Bilal, who didn't talk to me. Okay, Brittany, your turn. What did you say? ET tube?
I said ET tube, Doc.
No, I don't want to hear from you. Camille, what did you say? Fast.
I said ETT.
Okay. Who's the next in line who said LMA? Kafan? Kylie?
I did, Doc.
You said LMA. Okay,
I
let's
said
go.
LMA
What?
because you don't need a scope to insert it.
You do it blindly.
Yes.
So you don't need another skill. It's simply just learning put the airway in. And that needs a little bit. But so just thinking about it as a skill level. Just as a skill level. You're thinking about it. To put in an endotracheal tube, you need to learn the handling of 2 things. Yeah? With the LMA, you're just learning to do 1. So yes, the majority who said LMA, you are correct. What is the drawback of the LMA? What is the main drawback of the LMA? It is not a secure airway. See, good. So we do have, correct. So we do have to think about who we put it in and how we use it, but it is the easier airway to train, to have persons do. In so much so that for students, we actually have moved away from them absolutely needing to intubate. If they learn to intubate, that's fine, and we teach it, that's no trouble. But we require of them two basic airway skills they absolutely need to. They must be able to handle the airway with a mask and an inflatable bag, and they must learn to put an LMA in. Very important. Rodine, what are the indications for an LMA? Everything that does not need an endotracheal tube. Does that, I sound smart, don't I? I talk like a student, don't it? Don't I sound know to tell me? Don't that answer the don't that answer the question very well. Right? That's what it is. Okay, so really, once there is no risk to the patient of aspiration, you can use an LMA. Other things that will decide whether you can use an LMA is how long the anesthetic is going to be, do they need relaxation, etc. So there are a few other considerations. And then when you actually come to do the procedure, does the LMA sit? So I may choose that, okay, I'm going to anesthetize Sabrina Mitchell, so I'm going to put in an LMA for her. She's just having a fracture of her hand. They're going to be an hour. We're going to be fine. But then when I go to Sabrina's airway, this LMA just simply will not sit well. If it doesn't, then we'll have to decide on another way of controlling the airway. Right? Does that answer your question, madam? All right. Okay. So now we come to the ordinary face mask, anesthetic masks. All right. Excuse me. They're composed usually of plastic these days, silicone or rubber. There's a body that sits on a cuff. The cuff can be inflated usually by that. Excuse me. And the cuff needs to fit over the face to ensure a proper fit. So there are different sizes of masks. The inlet, which is here, to which the self-inflatable bag is actually attached in the picture, is 22 millimeters. It fits in it, and we can put an application around here that makes harness and stuff fit on it, so we can strap the mask into place. There are different types of masks that we can use. These are the anesthetic masks, and there are nasal masks that they use for dental anesthesia. That just fits over the nose. So Dr. Minot has in this thing in the dark ages, because we did make masks then of rubber. They were the same body, cuff, inflation. These are the prongs that can fit the harness on, and that's the connector. This is a special baby mask for probably a neonate. All right. Now they're transparent. So next question. My pollster. Gay, you're still my pollster. All right. What do you think are the advantages of using this mask over this mask? Okay. Kafan. You can see vomiters. What is etc, Harvey? Tell me etc. You know, students tell me etc, and I'm like, no, I'm silly. You know, as the examiner here, I know nothing. So what is the etc? Mucus, vomitous, what else? But that's very good. So you can see. All right. Blood, correct. Misting, Sion, excellent. Why is misting important? What does misting tell you, Sion?
The person is breathing or breathing out. I think.
That's not what it tells me. Well, that's what it tells me, but it gives me more information. It tells you you're in the right place. What do you mean the right place? It's a mask. It's on your face. Whose comment was that? Let me go back and see that one. Ooh, tell you, Miss Harvey. Expand, expand, expand. Give me a little more. What do you mean by in the right place? Because you're along my line, you know, but it's not quite as precise as I would like it. Because it's a mask. It's over the face. It's not. Yeah. So what does misting tell you, Daniel? That what is from, thank you, Sion, a patent airway. That's what it tells me. Right? It tells me when I see misting, I know that's what you wanted to say, Harvey. I know that's what you wanted to say. Yeah. So when you see misting means when they breathe out, you see misting. When they breathe in, the mist is, and it's regular. It means that the airway is patent. There's no obstruction. All right. And you combine that with the way the patient is breathing, whether it's synchronous thoracoabdominal breathing, and then you can make a decision on that. Good job. All right, you do have some other masks. So these are the anesthetic masks. These are the ones, when fitted properly and attached to an appropriate anesthetic oxygen delivery system, we can give 100% oxygen to the patient. Yeah, once the seal is excellent. All right, so then you have what we call just ordinary face mask. Everybody has seen this? Maybe if you've been a patient in a hospital, you have. Chad says less allergic reactions. You mean compared to rubber, Chad? Okay, I suppose, but it still wasn't that common. But I take your point. I think it's a good. Plastic is a far more inert material. Absolutely. Right, so yeah, these are just ordinary face masks. Oxygen comes in here, it's fitted onto the patient face. There are perforations in it, so air is entering from outside as well. And exhale here, air goes through these, and you get about an FiO2 of 0.4. Anybody know what a FiO2 means? Fractional inspired oxygen concentration. Yeah? Do you know what FiO2 you're breathing right now? Assuming everybody is sitting with the... No. 0.21. Good job. Who first said that? Leo said that. Leah said that. Christian said that. Radine said that. Jehan said that. Sion said that. Because it's the fractional inspired concentration. That is a decimal. Oh, yes, Janelle says. Don't get caught. Those are ways in which you can get a trick MCQ. You gotta be precise in how you think. All right? Gotta be precise in how you think. Right. So you get from these masks, by the time so it's oxygen enriched air, and you get about 0.4 or 0.5%. No more, usually not more than that, with 4 to 6 liters. Okay. They call them variable performance masks because the FiO2 varies according to the flow rate and what the patient's pattern of respiration, pattern and rate of respiration is, how well the mask fits, etc. So when you are an intern and you see a patient in distress, and you check the SpO2, the saturation, and you decide that a patient needs oxygen, and you've taken a history, and you realize that, okay, the patient is not a chronic obstructive airways disease patient and you're going to put them on oxygen on, you need to ensure all of these. Sit the patient up, make sure the mask fits well, decide on an appropriate flow rate, and see what happens. All right? Those are intern jobs. That's why we like have you all in. Because the next time we see you all, you're functioning very well. Imagine, everybody, imagine yourself as an intern. Do you? Tell me what you see. Imagine, let's go. Imagine Gay as an intern. She'd be no nonsense, don't it? She better be good though. All right. Then you have the venture. The goal of SpO2, you mean why do we measure it, Rodine? That's what you mean?
No, Doc. Like in these conversations, they always tell us that we shouldn't give too much oxygen because of the change in their drive. So, like, which percentage should we aim for patients with COPD?
There is no aiming of a percentage. If you have been looking after the patient, or if you have old notes for the patient and therefore know at what oxygen level they normally function, that's a great piece of information. So let's say, for example, the patient normally has a PO2 of about 65, yeah? And they normally have a PCO2 of maybe about 60. The patient comes to you in more acute distress, and your saturations you check, and the saturations are down at 55, which means your PO2 is probably somewhere around 30 millimeters of mercury. Yes? You're following me up to now?
Yes, Doc, I'm following.
All right. So then you decide this patient is not at their normal oxygen level. So they need some oxygen. Agreed? That's a clinical, thinking about a clinical decision that you've made. Yes?
Yes.
The caution that you do not go and put this, so when you take that saturation and see it at 55, or you do an arterial blood gas, and that saturation, am I back? Can you all hear me?
Yes, I can hear you.
Yeah. And you do the gas, when that saturation is 55, and you do that gas and the PO2 is like 35 or 40, the panic reaction, if you do not know the history of this patient, is then to slap on a face mask, probably with a reservoir bag, with 10 liters on the patient, yeah? Because you want the oxygen up. But in a patient with COPD, you need the oxygen up, but you need it up in a controlled manner, because you're not going to take them beyond what their normal is. I remember what we said this patient's normal was? 65, I said, I think?
Yes, it was 65.
So what you do when you have a Venturi Max, these are fit performance devices. They are used when you want to give precise amount of oxygen. If they are colored, let me see. These are the attachments. They are color coded, and they're color coded because they tell you what percentage is given if you administer a particular flow. Everybody can see that? So with that patient who is perhaps halfway down where he normally is, I may start him at a 28%. I would put on a Venturi mask, put it at 28%, put him at 4 liters per minute, and see what he does. So let's say that I do that an hour, his saturations are now about, let's do the ABG. The ABG has come to 45. Is he still hypoxic relative to himself?
Yes, he is.
He is. So at that point, having objective data, you now change it to 31% and 6 liters. That's what you do. And therefore, you might find that when that may cure him, or when you get to 35%, leaving him on for half an hour, and then checking his saturation and ABG, you find, okay, he has come up to about 90 to 92% saturation, and his PO2 is now 65. Are you going to go beyond that?
No, doc, I want it right there.
Why not? Why not? Would you not go beyond that in that patient?
Well, if my memory serves me right, what happens in these patients is that, okay, they have hypoxic pulmonary vasoconstriction. Is that the line of thinking that you want me to go down?
Go ahead. You tell it. I don't want you to give me specific line of and then we can sort it out.
Okay, you know what? Let me go to the basics. What I've been hearing from second year. So first year. What they're saying is that they have a switch from the normal. They now have a CO2 drive, right? So if that drive is suppressed, they will eventually stop breathing and they can't be weaned from the assisted ventilator support.
They have lost the sensitivity that we are tuned to, meaning our brains are attuned to CO2 because of the chronic high levels of CO2 that they always have. They have lost that. So what pushes them is the sort of the peripheral chemoreceptors is what keeps them going. Because the peripheral chemoreceptors respond to oxygen. The central ones usually respond to CO2. We're very, very highly tuned to CO2, which is why we can't hold our breath beyond a particular time. Because if you hold your breath, let's say you could hold your breath until you pass out. Yes? As soon as you pass out, your respiratory controller would say, yes, got you, and you'd begin to breathe. And you just wake up. Because we're very, very, very attuned to CO2. That's what makes us can't go beyond a certain thing. Yeah? But in the COPD patient, they've lost that sensitivity because their CO2 is usually chronically high. That's one type of it. There are two types of them, but that one type, the more common one we'll see is that one. Yeah? So this is the Venturi. It's a fixed performance device, and that's because these are what I call the Venturi principle. And you'd have heard it or will hear it when it comes on to, you'll do it again in asthma and COPD, you'll do it again, you may have done it in ABG's RMI Wednesday, and so on. So this is a repetitive thing. You have to learn. So everybody's homework today is to go learn the Bernoulli principle and the Venturi effects. It's from physics. Can be a little difficult, but go look at it, because what it is because when oxygen is sent through here, because the aperture is narrow, the kinetic energy of the system increases. And when it expands into this space, the potential energy increases. And because energy can't be lost, it then entrains air, and you get a particular mixture based on the flow that's coming through. And that gives you the fixed performance. So depending on the aperture and the flow comes in, and the falling pressure here entrains air to a particular amount, and then you get the mixture for which it is labeled. How do you know which one it is? They're color coded and they're labeled. So look at them. When you become an intern and for a minute you forget, just look at the connector, okay? It tells you both the percentage and the flow. Each of them does. Got it?
Yes, doc. Thank you. Okay, so one last question. So suppose you don't know the patient's baseline. Do you just choose some arbitrary number, or is there some principle to guide us there?
Low. You start low. If you do not know the patient's baseline, you start low and you gradually. So that means you'll be kind of starting low, monitoring the patient, and just gradually increasing. That's what, until you get to the PO2 target that you want, that will appropriately hold their PCO2 appropriate. Because what happens, as soon as you hyperoxygenate them, as soon as they're oxygenated about, they just retain CO2, and retain CO2 makes you sleepy and obtunded.
Okay.
Yeah. So what happens is that when people see the numbers, sometimes the knee-jerk reaction is to start higher. But you always have to ask yourself, is this patient a COPD patient? And if that patient is, it's better to start low and just gradually increase until the patient gets better oxygen. Got it?
Yes, so just to ensure to understand. So we start low, and whenever the patient's PCO2 is in normal range, we stop there.
Not the PCO2, no.
Mercy.
PCO2 might be normal, Rodine. The issue is that the patient is coming because they have lower oxygen than they normally do. So the assessment is clinically, this patient needs some oxygen. Yeah. But if you put them on so much oxygen that they are above where their normal oxygen is, they then don't breathe well and they retain CO2. So what you're doing is trying to administer oxygen therapy, but gradually, but in such a way that you have control over it, so that you are not going to take him above where his normal oxygen is usually. And how do you know that? If you don't know his baseline, you keep going up. You keep going up to improve his oxygenation. At the point where his oxygenation is adequate, and the PCO2 is not rising, that's the level you stay at. Because the moment you give him inappropriate oxygen, your next ABG will show a high PCO2. If you don't have an arterial blood gas, the next you will go and find him very somnolent and very sleepy and not up. So then you would know you have to back off that oxygen a bit.
Okay, thank you, Doc. It's crystal clear now.
Anybody else have any questions about that? Because you would have done with Dr. Burke Dunkley, you would have done the oxygen therapy and stuff, which even so this is just reinforcing it. All right. Right, so everybody is going to look at the Bernoulli principle. I should set a question or two on the Bernoulli principle just to make sure and review it. Because you would have done it in oxygen therapy. I just do it again and probably come across it in the asthma lecture again. So you need to sort it, okay? Make sure you understand it. Okay, nasal cannulae, ideal flows are 2 to 4 liters per minute, and it delivers this kind. So if you're somewhere, Rodine, where you do not have your venturi masks, you use nasal cannulae and you start off at low flows and go up. Okay? It's more comfortable for patients. They don't have to take off their oxygen therapy in order to eat and toileting and that sort of thing, which is very helpful. All right? Oropharyngeal airway, you would have seen it in BLS. It's inserted to maintain patency. It's put in the mouth, through the mouth, over the tongue. It's put in upside down in an adult and then turned around when it reaches the oropharynx. It has a bite block in it so that the patient can't occlude the airway, and it pulls the tongue forward off the pharyngeal wall and leaves a clear airway. However, if the patient has a gag in place, the patient is going to gag and possibly vomit, and therefore it is an airway that has to be used when the patient is unconscious. Oropharyngeal airway is used in an unconscious patient. All right? Again, it's color coded, can you see? To help with size. So you realize that color coding is used a lot in anesthesia. Right? Nasopharyngeal airways, these fit through the nostril nares and they fall. They should be, oh, one other thing. Who knows the measurement of an oropharyngeal airway? Here it is. What you can see that. They put it at the angle of the mouth to the tragus of the air. All right, it should just fit there. That means that is the appropriate size for that patient. All right. For the nasopharyngeal airway, goes through the nostril, right, and the distal end fits in the nasopharynx, just above the epiglottis. Bypasses mouth. It's in the nasopharynx. It can be tolerated in a semi-conscious patient. Okay, right? Very important. This. So if a patient is semi-conscious, you can actually put it in yourself. In an awake patient, you can anesthetize your nose, or you can just grease it up and put it in. Yeah. You're not gonna. If you look on YouTube, you'll see the respiratory therapists doing that. Yeah. But it can be tolerated in a conscious or semi-conscious patient, right? They won't gag or vomit. Definitely though, you don't use it. So an oropharyngeal airway always in an unconscious patient. Nasopharyngeal can be used in a semi-conscious patient and an awake patient, right? Proximal end has a flange, so it doesn't go down through the nostril, right? Very, very important piece of equipment, especially in a difficult airway. You need to keep. All right, laryngoscope, which we saw earlier. Video laryngoscope was what we saw being used, so you can see a screen. And then there's the ordinary everyday handle and blade laryngoscope. This is a Macintosh blade, and this is a Miller blade, which is straight. For the Miller blades, the tip of the laryngoscope goes behind the epiglottis, whereas for the Macintosh blades, they go into the vallecula. All right, it's a device used for intubation. You saw that being used. They have different types. It's usually the blade. The McCoy blade is this is the McCoy blade, right? Where there is an additional handle when that is clipped. The edge here, the hinge, is a hinge tip laryngoscope. They call it articulated laryngoscope or a hinge tip laryngoscope. All right, sorry. A hinge tip laryngoscope. Yes, thank you. So this is the handle with the light source in for the laryngoscope. But when you squash this area, it's connected to the tip and it flips the tip down that way. Gives you added vision. All right. and that's called a McCoy after the person, but it's called an articulated laryngoscope or a hinge tip laryngoscope. All right. And then there's a fiber optic laryngoscope. This still has a place. However, it is not as popular as it was a few years ago because the video laryngoscope has taken over. And the video laryngoscope is essentially a laryngoscope, but with a screen, whether handheld or beside you, where you can see what you're doing, as you saw in the video. And it has become quite an everyday matter to use. Glide scope or the video laryngoscope. Makes it easy, we use it to teach a lot so that you all can see the area anatomy and see what we are seeing, right? It means that I can teach and control juniors a lot better as well, right? Lots of different types. This is something that you all need to note. It's the recommended first line laryngoscope in the COVID epidemic, because we don't have to be right down in the patient's airway anymore. Although I never intubated like that. You can just, you literally are handling it and looking at a screen. So that takes you away from the airway. You saw that already, right? Some things that we normally, this is a McGill laryngoscope. First, you may have come across it in ENT, especially when we are doing a nasal intubation. When we put the endotracheal tube through the nares and into the pharynx, we use the McGill forceps to help direct it into the larynx. It can remove foreign bodies, and it's used for insertion of throat packs if we need to, and you have it in adult and pediatric sizes. All right. This is a very simple device. It's called a gum elastic bougie. We use it in difficult intubations. We insert it. If you know what the Seldinger technique is, to set up, for example, a CVP or an art line, it is where you locate the vessel, put in a wire, and then thread the catheter over it. This is what I call the Seldinger technique to the airway. Do laryngoscopy, put in the bougie into the larynx, and then you railroad the endotracheal tube over it. The end of it is, I still have it, the end of it is a little more curved, so this is the natural curvature of it, and then there's a slight kick. And what that does, when you put it in, you can hear it clicking, you can feel it clicking over the cartilaginous rings of the trachea, almost like on a pavement. Click, 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 you can feel it. And it helps you to be certain, if the airway is really difficult and you don't get a good vision, that you're in the trachea. Right? This is with a gum elastic bougie loaded over it. Right? There are stillets. These are metal devices. They're usually covered, and they offer rigidity to a tube, and they offer you the ability to shape the tube as well. So it's a malleable metal wire. When you put it in, you can shape the tube. So if I want to make a J out of it, depending on how the anatomy of the patient is, then I can use it. And you have different sizes. Still very useful. And a reinforced endotracheal tube is very floppy. Because of the coil within its walls, it's very floppy. And you need a stillet at least in it in order to intubate with it. All right? So monitoring. All right? So everybody tell me, what is the first basic monitor? First basic monitor. Hello, hello. Today's what, Wednesday? You can't have rot so much. Anesthetist, Imani, first off. Yes, Christina. Trained anesthetist. That's your first monitor out. You gotta have a trained anesthetist present. All right. So there's some basic monitors in addition to the anesthetist that the American Society of Anesthesiology has put out. Non-invasive blood pressure, ECG, capnography, pulse oximetry, and temperature. We don't always do temperature, but it is recommended. And because they have a higher incidence of malignant hyperthermia, even though it is still rare, they are very particular about it. And you may have to have invasive monitoring, like a direct arterial line, arterial line for direct arterial blood pressure monitoring, or CVP lines. And pulmonary arterial catheters are used now very rarely. All right? Anybody has, let me see the hands of those who have tried intravenous cannulation. Excuse me. All right. Okay. So we have I have on the site arterial puncture IV placement.
I have to stop and tell you guys about Lecturio, Lectur.
Top 8. Okay, let's go. I'm coming, Siobhan. I am coming. Give me a minute. Right. So
so you're at the point where you need to start an IV.
I'm not going to show you the whole video. I'm just letting you know that these are videos I have sought and put up on OURVLE, so go and have a look. All right.
If you aren't comfortable yet starting IVs, the most important thing to do is not to panic. You may also need mainly the antecubital thigh, unclenching his fist, doing both tricks at once.
Right. Tourniquet on, and so on. Anybody who
Nice. So now step 1 is complete. Dominant hand a few inches distal to the vein. Bevel up. What does that mean? Well, here's a little graphic. You can see that the bevel, referring to this diagonal portion of the needle.
All right. So it is there. Right. Go have a look. Did not find one that had people of our color, because I think it is better. Know that you are better trained because you are used to darker skin. Caucasian or fair skinned, it's easier to do these procedures generally. Yes, Siobhan.
No, Doc, you said raise your hands if you've done an IV. So I thought that was different. Sorry. Okay.
All right. Let's go back. Okay. So we move on to spinal needles. We're coming down to the end of it. There are different kinds of spinal needles. And usually, so this is the Quinky, that's a common one. You'll see it all the time. The bevel is directly involved with tip of it. These are different types. These are what they call pencil point needles, meaning the tip of them is like a pencil, shaped like a sharpened pencil, and the orifice is a bit in. The reticle is the furthest, the sprot is close, and the gerty is closer to the tip, closest to the tip. And there are advantages. The pencil point needles lead to less headaches, generally, than the Quinky needles. So, and they're much more dull. So you may need to do that. Again, see the color coded? Everybody see that? Again, 25, 24, 22, 18, I think. 20, maybe. 18. Sorry. Thank you. 26. No, 25, 24, 22, 20, I think. This might be 18. All right. The bigger the number, the smaller the needle. All right. You can have 27 gauges as well, and up to 29. Larger the gauge, smaller the needle. 27 and 25 gauges are preferred for young, pregnant female because they have a higher incidence of post-dural puncture headache. Number of attempts at a spinal and the larger sizes increase the risk of a post-dural puncture headache, and you'll learn about that. All right? Needle lengths vary depending on the patient we're doing. A child is going to need a shorter needle. A plump person with a lot of subcutaneous coverage on the back, they're going to need a longer needle, of course. That follows. Right? Can you see? Yes, that's a 20. So the yellow is a 20 gauge. Can you see that? Yeah. This is the introducer. Every needle has an introducer in it. So you don't put in an open needle. There's always an introducer. And when you think you are into the subarachnoid space, you take out the introducer. And for the subarachnoid space, the end point is seeing CSF. These are epidural needles. Epidural needles are placed in the epidural space, just above the dura, meaning not in the subarachnoid space. So the end point for them is what we call loss of resistance, and you'll do a bit of that with, I think it's Dr. Harvey, on Friday. Notice that these are graduated. Okay, they are centimeter, 1, 2, 3, 4, 5, 6, 7, 8 centimeters. Another 2 to the tip of, to the opening of the needle. That would make it about a 10 centimeter needle. It's color coded again, depending on size. And an epidural catheter, let's see. An epidural catheter is placed through the needle. The first marking on the catheter is at 10 centimeters, and then they're 1 centimeter apart. The double marking, that would make 20, and again, and so you go. Note that because the needle is graduated, when we put it in wherever we find loss of resistance, say I put it, and when I got loss of resistance, the skin was at this point. Can everybody see my cursor? So that means the depth of my epidural space would be 1, 2, 3, 4, 5 centimeters. Yes? So that's where skin is. So I'm now going to put the catheter in. Clearly, I need to have beyond, I need to accommodate for this 5 centimeters plus whatever amount of catheter I want to leave in the space. Yeah? This first marking would be at 10 centimeters. So when I put it in, and I put it here, first marking, nothing is out of the needle as well, as yet. Okay? And then, so I'm going to put it into 10, and then I'm going to feed it another 3 to 5 centimeters. Sorry, the second one is 15. What did I tell you? Never mind. All right, this one, 3 to 5 centimeters in. So I'm going to have 10 centimeters and then 5 centimeters. So I have 5 centimeters in. And then I'm going to pull the needle out while keeping the catheter fairly firm. Yeah, so it doesn't get pulled out. And then I'm going to think, okay, so the depth of the epidural space was 5 centimeters, and I want to leave another 5 centimeters. So once I take out the needle, I would now want to pull that catheter back to 10 or 11 centimeters at skin, simply because it will be 5 centimeters to the epidural space depth, and then the rest would be accommodating for the amount of catheter in this space. All right. You need to know the details so much at this level, not necessarily, but you do need to know that the needle is graduated and the catheter is graduated so we can judge how much catheter we need in this space. Yes, that's really what that is about. And this is the whole kit. You just need to know that's the filter, nothing goes through it. This is the loss of resistance, needle, and so on. As I say, Friday, we'll get talked about it. All right. So really, what happens is that we have to check all our equipment, right? We have to make sure when you go to see the patient preoperatively, discuss with the patient, discuss with the surgeon what the surgery is, and you come up with a plan for the anesthetic for that patient. You then have to decide how you're going to manage it. Is it a general or is it a spinal? If it's a spinal, is it a general or a regional? If it's a regional, do I have the ultrasound machine? Do I have all the requisite equipment? Am I trained well enough to do it? Do I have all the resuscitation thing? Do I have all the etc.? If it's a general, has the machine been checked? Is suction available? So on. Do I have the airways? Do I have which laryngoscope I'm going to use? How am I going to manage the airway if I'm not? Do I need a laryngoscope? Am I just going to use everything? So prior to the procedure, you have to check that all equipment that you will need are present, checked, and in a working condition. So you don't just look and say, oh, the laryngoscope is here. You need to pick up the laryngoscope, open it, make sure that there is light in it, it sticks, it's not going off. So you have to ensure that the equipment present and working. Questions? Any questions, anybody? All right, you know how to find me. So have a good afternoon. Your next lecture is at 1:30. So get up, get some lunch, walk about, exercise. That means walking around for 10 minutes or so. All right then. Have a good afternoon. Bye-bye.